We will continue with complexity because neuroradiology and sequences, MRI sequences and other imaging becomes more and more complicated, and Julia will help us to understand. So Julia,
I promise it's much more easier now. I'm the last in the row for today, so thank you for all of you who are still participating. My name is Julia Furtner-Srajer, and I'm a neuroradiologist from Austria, and I'm delighted to give a talk today about the advanced imaging in brain tumors. These are my disclosures. I decided to split my talk into three main topics. The first is, do we really need advanced imaging? And if yes, when do we need it? The second is it important to inform our radiologists that our patients get IDH inhibitor therapy? And in the last minutes, we will focus on a response assessment update. So, do we really need advanced imaging? I will show you some cases and decide yourself if you think it would be helpful or not. This is a 35-year-old female patient presented with a suspected brain tumor in the right parietal lobe. And now you can see these images and you have to decide which is your diagnosis. Could it be an astrocytoma IDH mutant, grade 2, a glioblastoma, a bacterial abscess, a lymphoma, a tumor factor demyelinated lesion, or do you say, I don't know, please can I have more images? If I ask this in this session, I think it's very obvious that if F is the right answer, I will always see more images if they are available. So we have them, and we see that there is a flare lesion in the parietal lobe. You can see very tiny spots of contrast enhancement in the periphery, a moderate diffusion restriction, not increased but decreased perfusion, and a high choline peak. So I think it's kind of a hard case, at least for me. So when we go further, let us look at the differential diagnosis. When it comes to an astrocytoma IDH mutant grade 2, we typically have a hyper-intense flare signal at the periphery and hypo-intense in the center. We usually do not have contrast enhancement and no diffusion restriction. We have no increased perfusion, so that would fit. But it is suspicious that in our case there was a contrast enhancement here, it is not. In the MR spectroscopy, we see a choline peak, a moderate increased choline peak stands for cell turnover, and a reduced NAA peak. A glioblastoma has this vivid contrast enhancement at the periphery with a central necrosis, a moderate diffusion restriction, but a very intense perfusion in the solid tumor parts, and again a very high choline peak. But what does not fit with our case is that there is a very intensive perfusion signal, which was the case in our patient. When we come to non-tumoral differential diagnosis, an abscess routinely looks like this. We have this thin linear contrast enhancing rim, the abscess capsule, like drawing a line, very homogeneous, and this is also reflected on FLAIR and T2 weighted image, where you can see this classical double rim sign, so a dark line and a bright line, also reflecting the capsule. Of course, we have no perfusion within the center and extensive diffusion restriction due to the pus. And again, in the MR spectroscopy, we have very high lipid peaks due to the cell death. When it comes to primary CNS lymphoma, I always say it's kind of the king or the queen of diffusion-restricted tumors. We typically have this periventricular location, diffusion restriction. When we have an immunocompetent patient, we have this homogeneous enhancement with an irregular border, but we don't have an increased perfusion. And we have, again, a high choline peak due to the high cell turnover. And there are these tumefactive demyelinating lesion, and as you can see, this is our case. So we have kind of open ring contrast enhancement, which is very faint in this case, a moderate diffusion restriction, and decrease in perfusion because it's not a brain tumor, and a high choline peak to do the inflammatory reaction. What also can help you here is that you can see small, tiny, hyperintense dots, which are MS plaques, but they don't have to be there in any case. So I think these cases are very tricky, and I would go for further imaging just to include other differential diagnoses. Next case. A 60-year-old male patient with suspected glioblastoma shows this lesion in the T1 contrast enhancing images. And now what do you see here? We heard about it in the afternoon already. Do we see the whole tumor extents depicted on this image? Do we only see the part of the tumor with the disrupted blood-brain barrier, or do we see the most metabolically active part of the tumor? And at least since the publication of Felix Sam, we know that in imaging we only see the tip of the iceberg, so there will be certainly tumor cells around the contrast-enhancing lesion and also at the contralateral normal-appearing hemisphere. But this contrast-enhancing lesion may not always represent the most metabolic active part, as you can see it here. This is in this patient dorsolateral, as you can see it on the FET PET image. So be aware, we only see the disrupted brain-blood barrier, not more and not less. There was a study from a group of Amsterdam, and they compared imaging findings of different MR sequences and PET imaging with histopathological features in the peritumoral region. So you can see there was the tumor, and they also did biopsies around the tumor, so with 1 centimeter around. And what they found was that diffusion-weighted imaging and amino acid PET was much more significantly associated with the histological features than T1 contrast-enhancing lesions. So this was the case in contrast-enhancing gliomas. In non-contrast-enhancing gliomas, there was no significant improvement compared to FLAIR images. The next case is the nightmare for all radiologists. It's a 78-year-old patient with breast cancer and brain metastasis. And now there's a new contrast enhancement and increase in size of brain metastasis 3 months after stereotactic surgery. And now, usually in the tumor board, all eyes are on me, and they ask me, what is your diagnosis? My typical answer is, I don't know, based on this image, so we have to do further images. I'm not ashamed anymore, because there is a guideline from the German Society of Radio-Oncology who says that currently no single modality provides absolute certainty, and this is an interdisciplinary approach. On the standard MRI, we see increase of edema and contrast enhancement in both recurrent tumor and therapy-associated changes, and only the multimodal MRI sequences such as diffusion-weighted, perfusion, NMR spectroscopy, and, if available, amino acid PET can give you more information. This is also underlined by these studies. You can see that the perfusion, diffusion, and also the amino acid PET shows alone a very high sensitivity and specificity. However, the combination of PET and MRI outperform each single technique. So come back to our case. We saw this lesion. It was increasing in size, a new contrast enhancement, but there was no diffusion restriction, there was no increase in perfusion, and there was no increase of amino acid uptake. And in the MR spectroscopy, you can see a moderate choline peak, but a very high lipid lactate peak representing the cell death of this lesion. So this is a typical case of therapy-associated changes, but as we all know from the clinical routine, those cases are rare. Most of the time we have 3 sequences going for recurrence and 4 sequences going for therapy-associated changes, and we have to decide or do another biopsy or something like that, because also in histology there is a mixture part, and we have to decide on our gut feeling and on all information we have. So it's important to have as much as information as possible. When it comes to IDH inhibitor therapy, do we know as radiologists what to do, or is there anything we should be aware of? I think that I should talk about the Indigo trial because Martin van der Beijn talked about it already. But since then, we as radiologists were more and more asked, is it possible first to detect IDH mutation in gliomas? And the second thing, should we be aware of something when monitoring IDH inhibitor therapy patients? So starting with the first, the detection of IDH mutation in gliomas. Let me say there are hints or signs that this could be an astrocytoma IDH mutant. For example, the FLAIR-T2 mismatch sign, we already heard it today. When you have an extensive area of high signal on the T2 weighted image, and you have in the corresponding FLAIR image a relatively hypo-intense signal, most of it in the center of the lesion, this is a very characteristic feature of an astrocytoma IDH mutant. When we came to higher grade, usually an astrocytoma IDH mutant grade 4 glioma represents with a large part of non-contrast enhancing tumor and only shows some very tiny spots of contrast enhancement. In comparison, glioblastoma IDH wild type usually show this vivid contrast enhancement in the periphery and the central necrosis. And you can also use MR spectroscopy to detect the oncometabolite 2-hydroxyglutarate at 4.02 and 2.25 parts per million. These peaks are not depicted in IDH wild type, so glioblastomas, or in the normal brain tissue. Now, what should we be aware of when it comes to therapy monitoring during IDH inhibitor treatment? There are 2 things. The first is, if you start treatment and you do a follow-up examination very early, so 3 to 6 weeks after therapy initiation, there may be an increase in perfusion and in tumor volume size. Please do another follow-up examination, because this does not necessarily be associated with progression-free survival. Do another examination about 2 to 4 months after therapy initiation, because there are findings such as tumor volume increase in perfusion, or decrease in ADC signal were significantly associated with progression-free survival. The second thing is that after 16 months of therapy initiation, a group found that the patient develops very small punctured contrast-enhancing lesion under 1 centimeter that resolved or stabilized in the follow-up examination. So if you find such lesions around this time point, please do another MRI follow-up examination just to be sure that this is real tumor progression or it's just such a lesion that resolves. You can also again use the MR spectroscopy, but be aware. This is the same patient, and the gray columns show us the IDH inhibitor intake. The 2-hydroxyglutarate reflects the IDH inhibitor intake, but were not always associated with the tumor volume. So as you can see it here, when we start the intake, the 2-hydroxyglutarate peaks decreases immediately. But when we look at the volume, as I told you before, it goes a little bit up until later on it stabilizes. So this is only reflecting the IDH inhibitor intake and not really the tumor volume. So when we come to the response assessment criteria, in the last 15 years, we used different RANO criteria for high-grade and low-grade gliomas. And 2 years ago, Patrick Gwen did an update. And now we're using RANO 2.0 criteria. They are for high-grade and low-grade glioma. A few months ago, Nathalie Albert published PET RANO criteria also for high-grade and low-grade gliomas. But be aware, the PET RANO criteria only PET imaging alone criteria. So they do not take into account MRI features, clinical status of the patient, or corticosteroid use. They're just imaging. We previously were used to define up to 5 target lesions. Now in the RANO 2.0 criteria, if we only have contrast-enhancing or non-contrast-enhancing lesion, we define up to 3 target lesions. If we have a mixture, we are allowed to define 2 contrast-enhancing and 2 non-contrast-enhancing target lesions. And in the PET RANO criteria, we may define 3 target lesions with a volume over 0.5 milliliters, and the lesions have a 1.6-fold mean background activity. I think one of the most important things in the new RANO criteria is the baseline MRI. And why is this? We were used to use the post-surgical MRI as baseline, which was 48 to 72 hours after tumor resection. Now we are recommended to use the post-radiotherapy MRI 4 weeks after the end of radiotherapy to reduce the impact of postoperative changes. But be aware that this imaging time point is established in your institution, because we conducted a pan-national study in Austria, and we found out that no center did MRIs at this specific time point. And the second one is, be aware of the radiation-induced changes and do not misdiagnose them as early recurrence. And in the PET RANO criteria, it's kind of easy. You just do at least 2 weeks before treatment the PET examination. So this is my last slide. When you go out of this room today and having dinner with your friends or drinking some glass of wine, and someone will ask you, what can you remember of this session? Please remember at least some of this. We use advanced MR sequences at least of the time of diagnosis to find the right diagnosis or exclude other differential diagnoses. And we use it in terms of when we are not sure, is this tumor recurrence or are these therapy-associated changes. When it comes to IDH inhibitor therapy, remember that an early increase of tumor volume and perfusion may not necessarily be associated with progression-free survival. And if around 16 months after the start of therapy, you find some small punctured contrast-enhancing lesion, do another MRI examination, because they may resolve or stabilize and are not also always associated with tumor progression. And when it comes to response assessment, now use the RANO 2.0 criteria. Be aware that you implement the baseline MRI scan 4 weeks after the end of radiotherapy, and be aware of the radiation-induced changes at this time point. Thank you very much.
Thank you, Julia, for this nice presentation. Any question? Yeah, some question?
100 questions for you. No, just a couple. The first one is, what is the evolution of the mismatch sign during time? Is it, for example, can we use the mismatch sign to follow up patients even during anti-IDH treatment?
I would not rely 100% on this sign. It's good for therapy, a native grade 2 astrocytoma, but also in grade 3 or in grade 4 astrocytoma, I don't think it's reliable anymore. And also, I have no data on when it comes to the IDH inhibitor therapy. I don't know it yet, but it's just one sign of many. So,
second question. Yeah. 98, yeah, absolutely. Do you find differences in response during IDH inhibitors according to histology, so astrocytoma or oligos?
Differences in what?
In the response assessment during the treatment with anti-IDH agents?
I have no information about that. I think it's a little bit too early, maybe.
Yeah. And the last one is...
yeah.
No,
so
no.
What I wanted to say is these information are based on very small sample sizes, of course. But at least we have anything.
When you say that after the beginning of the treatment, you may observe an increase in tumor size, I'm not sure it's tumor. Maybe it's in T2 size.
Yes. Increase of the size of the lesion.
Yeah.
And of the perfusion of the lesion. Yeah.
Thank you.
Okay, we will keep the 96 for
the dinner.
The first case you presented was very tricky. So I saw that the choline peak was related to cell membrane renewal and cell proliferation. So in this case, is the choline peak related to myelin remodeling or to proliferation of immune cells? What do you think?
There is a mixture, and it could also be due to the inflammatory scene of this kind of lesion, but the MR spectroscopy in these lesions may be very tricky and misleading for tumor, because when I see such a high choline peak, I immediately think of tumor because of the high cell turnover. But I think it's kind of a mixture of cell membrane loss, of inflammation processes, but this is tricky.
Hi, Julia. Thank you. Great talk. So we are going to see more and more patients treated with IDH inhibitors, of course, in the future. But we still rely on bidimensional, evaluation of the response, even if we don't see great change. But do you think that we should switch to volumetric assessment as for tumors? So because I think bidimensional is really tricky, especially with IDH inhibitors.
Yes, and especially in slow-growing lesions, it's also very tricky. If you just use 2 diameters, it's always better to have volumetric measurements. And one of my favorite sequences is diffusion-weighted image, because then you can also see a transformation or to more malignant parts of the tumor without a big change of growth. So when I read images, I take all the sequences I have, and usually also in the outpatient clinics, we have this T1, T2 flare and also the diffusion-weighted image. And I think we have to look at in summary, so we have to take everything in account we have, but volumetric measurements will be the future, I'm pretty sure.
Thank you. Julia, can you show again the punctuated aspect after 16 months of IDH inhibitors, just to remember it properly?
Say stop.
And how it looks like. We saw it already, right? The punctuated aspect. IDH therapy. At 16 months, you said, right?
This one, yeah,
Yeah.
yeah. There was no image, but it was a...
I didn't.
just a sorry. Yeah.
You don't have any
No,
images?
no, 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 no.
Okay.
Sorry.
So that's why I didn't see it.
Yeah.
And the other point, does artificial intelligence enters the field of neuroradiology as it did in the other field of radiology?
Yes.
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 And
Especially in detecting lesions such as brain metastasis, in differentiating different lesions, so finding the right diagnosis. I think these are the main things that AI could help in the near future.
in near future, it's not used in routine,
No,
like in
not now.
thorax imaging,
No,
for
no,
instance.
no. What is used already are some atrophy programs, but they do not work very
Very well.
reliable.
So far. Okay. Thank you very much, Julia. I would like to thank all the speakers for their very high quality presentation and talk, and I would like to thank the audience as well for attending. And see you soon, maybe next year.